The Vital Surgery Training Program is the flagship initiative of the Global Surgery Lab, a section of the Branch for Global Surgical Care at the University of British Columbia. I'm Sharza Jaharifard, a pediatric surgeon at BC Children's Hospital. My colleague is Emily Yosh, a trauma surgeon at Vancouver General Hospital. In addition to our clinical work in Canada, we each have extensive experience working as surgeons in low-resource settings, predominantly with Médecins Sans Frontières, or Doctors Without Borders. Together, we lead the Global Surgery Lab and the Vital Surgery Training Program. In 2015, the Lancet Commission shed light on the massive gap in access to surgical care worldwide. Most alarmingly, the Commission found that 5 billion people do not have access to safe surgery. Access is most limited in low-income countries, where 9 out of 10 people cannot access basic surgical care. Worldwide, the inequity in distribution of surgical procedures is staggering. Of the 313 million surgical procedures performed each year, only 6% occur in the world's poorest countries, where more than a third of the world's population lives. Further, a quarter of people who have had a surgical procedure will incur financial catastrophe as a result of seeking care. This financial burden is highest in low-income countries, and within every country lands most heavily on poor people. The World Health Organization has determined that achieving universal health coverage depends on the provision of safe and affordable surgical care. However, surgical care has often been considered the last frontier of primary health care. Despite global agreement that surgical care is a cornerstone of healthy lives in healthy communities, there has been slow progress in improving access to safe surgery for the world's most vulnerable populations. The main impediment to global expansion of quality surgical care is a critical lack of a trained surgical workforce in the world's poorest countries. The surgical workforce is typically quantified by the number of surgeons, obstetrician-gynecologists, and anesthetists per 100,000 people. This graph shows the mean number of surgical providers per 100,000 people organized by income group. The Lancet Commission set a target of greater than 20 surgical providers per 100,000 people. As you can see, the mean ratio in low-income countries is just 0.7, 100 times lower than in high-income countries. In low-income countries, furthermore, the already paltry surgical workforce is unevenly distributed, leaving many rural and remote regions without any surgical providers at all. For example, in the Central African Republic, in 2023, there were only 14 surgeons and 18 obstetricians, for a country with a population of more than 5 million people, and every single surgeon and obstetrician was based in the capital. We call countries and regions with little to no surgical workforce and limited capacity to train surgical providers medical deserts. Vital Surgery is a task-sharing surgical training program created for low-resource settings. Task sharing is an innovative solution to solving the surgical workforce problem. Broadly speaking, task sharing involves training non-specialist doctors in essential surgical skills so that they can share the load of surgical provision, especially in rural or remote areas. While task-sharing programs represent a newer approach to responding to the surgical workforce shortage, they are not untested. A well-established example is the CAPACARE training program, which was launched in 2011 in Sierra Leone. Graduates of this 3-year training program are recognized by the Sierra Leonean Ministry of Health, and in extensive studies have been shown to provide safe surgical care in their communities. In fact, one study showed that mortality for some procedures was lower in the hands of CAPACARE graduates than in those of fully trained surgeons. Our experience working as surgeons in conflict and post-conflict settings in sub-Saharan Africa inspired us to create the Vital Surgery Training Program. While Emily and I undoubtedly saw the immediate impact of our work on our patients, we felt frustrated that we weren't able to improve the capacity of local providers to deliver safe surgical care. Vital Surge was born out of this desire to leave a lasting impact on surgical care provision long after our departure. Vital Surge teaches non-specialist medical doctors essential surgical skills in places where there are few or no surgical providers. By providing context-relevant surgical training in situ, where our trainees already practice, VitalSurge aims to close the gap in surgical care in medical deserts. The Vital Surgery Training Program was originally conceived as being taught on the ground by surgeons affiliated with the Global Surgery Lab. The COVID pandemic, however, forced us to pivot to a hybrid training approach. As such, our curriculum has two main parts: a didactic component delivered primarily online, and a practical component delivered on the ground by surgeon trainers. Our shift to a hybrid training approach has had three main benefits. First, facilitating partnership with other like-minded organizations. Second, decreasing our environmental impact by drastically reducing our travel-related carbon footprint. And third, allowing development of an open access curriculum that can be used by anyone, anywhere that there is a low-speed internet. VitalSurge needs to be delivered in a facility that has basic surgical infrastructure, as well as a surgeon trainer who can teach and supervise trainees on a daily basis. For this reason, we partnered with Médecins Sans Frontières, or MSF, an international independent medical humanitarian organization that provides medical assistance to people affected by conflict, epidemics, disasters, or exclusion from healthcare. MSF has established standards for surgical care provision, follows strict surgical safety protocols, and employs skilled surgeons. Through this partnership, we have ensured a safe training environment for our trainees and their patients. VitalSurge training sites are selected in collaboration with MSF, targeting regions in sub-Saharan Africa where MSF supports functioning hospitals with a minimum standard of surgical infrastructure, but few, if any, local surgeons, and few, if any, surgical training programs. Notable medical deserts in sub-Saharan Africa include South Sudan, the Central African Republic, and the northeastern parts of the Democratic Republic of the Congo. This diagram summarizes the Vital Surgery Training Program, which is divided into a 10-month foundation phase and an 8-month consolidation phase. We begin the training program with a 1-month-long boot camp, during which trainees learn fundamental technical and non-technical skills. During the remainder of the foundation phase, trainees complete didactic modules while concurrently training in the hospital. 1 afternoon per week is reserved for weekly lectures and simulation. During the consolidation phase, weekly lectures and advanced assigned readings continue, but greater emphasis is placed on mentorship for practice and increasing trainee independence. The last month of the consolidation phase is the capstone rotation. Here, trainees integrate into district hospitals under the supervision of an MSF surgeon. Following completion of the training program, graduates will have access to ongoing mentorship from surgeons. Now, let's dive into each component of the training program in more detail. The didactic component is comprised of 10 modules that address core competency for non-specialist doctors practicing in rural or remote settings. 1. Safe surgery. 2. Airway and basic anesthesia. 3. Trauma resuscitation and bleeding. 4. Source control. 5. Acute abdomen. 6. Fracture management and basic orthopedics. 7. Burns. 8. Pediatric surgery. And 9. Obstetric and gynecology. And 10. Urology. Each module is led by a surgical specialist with experience working in low-resource settings. This individual organizes the live weekly lectures and acts as a remote resource for trainees. During each module, trainees read online content and complete pre- and post-module quizzes. Modules are not meant to replace a textbook. Rather, they are designed as concise and interactive summaries with supplemental diagrams, tables, and other media. Each module includes descriptions of all 44 essential surgical procedures as outlined by the World Bank. These descriptions are further supported by short 5 to 8 minute videos that demonstrate how to perform key surgical procedures. To date, we have filmed over 25 videos in our UBC Cadaver Lab. The practical component consists of hands-on training and simulation. Trainees rotate through different departments in the hospital or in a partner hospital so as to ensure exposure to all relevant specialties. VitalSurge is founded on Competency by Design Medical Education, or CBME, which is a new method of training and evaluating doctors that has been implemented throughout the world. The keystone of CBME is Entrustable Professional Activities, or EPAs, which are the key activities that graduates of a particular training program must be able to perform independently. Importantly, EPAs include both technical and non-technical skills. Together with our partners, we have designed 63 EPAs for the Vital Surgery program. Trainees are regularly evaluated by their supervisors on the basis of EPAs. Here, you can see Dr. Anna, an MSF obstetrician gynecologist, evaluating Dr. Joseph, a South Sudanese trainee, after he performed a surgical procedure. As you can see in the photo, the evaluation occurs using an online form on a tablet, which facilitates ongoing monitoring and evaluation. In addition to EPAs, competence is also measured by online case logs, pre- and post-tests for each module, and regular written and oral exams. Trainees are rigorously evaluated. A competency committee meets every 3 months to review EPAs, case logs, pre- and post-test results, and feedback from MSF surgeons. After 10 months, trainees will complete written and oral exams. Following this, the competency committee will meet and determine each trainee's eligibility for promotion to the consolidation phase. At the end of 18 months, trainees will complete final oral and written exams, and the competency committee will meet one final time to assess readiness for graduation. Successful candidates will receive a certificate and begin practice as physician surgeons. Thus far, we have implemented the Vital Surgery training program twice at an MSF-supported hospital in Awil, South Sudan. We have trained a total of 4 medical doctors over 2 cohorts. Our goal is to expand to other medical deserts across sub-Saharan Africa, starting with the Central African Republic. The Vital Surgery training program aims to drastically increase surgical capacity in medical deserts. In Awil, we have increased surgical capacity by 400%, from 0 local surgical providers to 4 over a period of just 5 years. Our next steps are to expand Vital Surge to multiple other sites in South Sudan, as well as to unroll the training program in the Central African Republic. Thanks for your attention and support. For more information, please contact us, visit our website, or follow us on social media.